Health. His first empirical paper was published in JAMA in 2012 and was an editor's choice, and that was on medication administration. Today he's talking about more of the EHR use.
Thank you. Well, it has been a long time actually I gave a public talk, so if I do injustice to this, please forgive me. And the other thing is, of course, the working paper. So while coming on the way, I was thinking about, research is something like wine. As it ages, it actually becomes high quality. And this particular bottle of wine was bottled in spring of 2015. And I don't know what is the status right now, so I'm just trying to show, I'm going to show you any feedback that can help me to improve the paper, because I have not actually written the manuscript itself. It would be great actually, and you're welcome to point out any flaws that are there. And yeah, with that said, so let me, of course, the topic is about actually the relationship between the hospital-acquired infections and EHR meaningful use in the US hospitals. Obviously, many of us know, maybe either through personal experience or maybe someone in the family or hospital-acquired conditions are actually a serious problem in the healthcare delivery. And it has attracted a lot of attention, and a lot of changes that are being made in the healthcare systems. And as part of the value-based quality care program that are nowadays up in the CMS, one program is actually how to reduce the hospital-acquired conditions, and it's sort of an incentive mechanism that works and tries to influence the hospital decisions and to bring out the necessary structural changes. Some of the key infection categories that are being considered is actually catheter-associated urinary tract infection, where in short it is CAUTI. The second is central line associated bloodstream infection, CLABSI, and then there are many other, actually about 8, and probably it will increase, the list will increase over the years. Right now actually in the pay for performance or the value-based quality purchasing program, what is happening is about 65% of the penalty is based on the score that the hospital gets on exclusively on the CAUTI and CLABSI infections. The rest is the remaining 35% is on the other 8 categories. Okay, and recently CMS, which administers the Medicare and Medicare program, and Medicaid is actually run through the state agencies. They are actually expecting over the year hospitals will actually will be able to reduce this, so that the quality of care is actually better and there is a less cost of care ultimately comes down. So the question is actually why we are talking about the EHR systems. EHR system is not like, it's not a something, it's not really a fast food kind of concept. Okay, it takes a long time to realize the benefits of any IT systems. Forget about the EHR. Any IT system in life that we use, the ultimate benefit of the system comes over time. It is not instant gratification. So the whole concept, even the federal agencies, when they started, the basic idea is actually to promote the EHR adoption so that everyone actually starts capturing the data in the right format, and then they start sharing. And later on, they are actually implementing the clinical decision rules so that they can make better decisions, and ultimately over time, maybe 5 years, 10 years down the line, you will have an improved outcome at the system level. Individual providers will experience the benefits shorter time, but overall, when you are looking at the national economy level, then the overall improved outcome will take much more time. So what is the status current now? I was just looking at the CMS website, and it shows that there are about almost 356,000 physicians who are registered, and out of which Medicare eligible are about Medicare eligible professionals, then the Medicaid eligible physicians who are about 184,000 and odd. Hospital out there are about like 5,000 some non-federal hospitals, out of which about 4,800 have already actually are under the program and getting the money, of which 4,400 are serve the Medicare and Medicaid patients both, whereas there are some who serve only the Medicare or they take the Medicaid only. How much money that has been spent? $31 billion so far. Under the stage 1, how many of you actually know about the stage 1, stage 2, stage 3 meaningful use requirement? Okay, well, so it would be a bit difficult, but okay, so it's basically sort of like this. Okay, this is not a real stage 1, stage 2, but it is something like that. Stage 1 where you are actually capturing the data and then making little bit of data transfer between the units. Stage 2 sort of it includes the CPOE implementation. Everyone knows what is CPOE, computerized physician order entry system. So where actually you make use of clinical decision rules, and a lot of research related to that is done here in SBMI. So I don't think I have to tell that. Then the third is basically you have stage 3 where you have fully matured system. Okay, expect hopefully in all the places. So stage 1 so far we have spent about given away about $8 billion to physicians, whereas 11.6 to hospital systems. Physicians normally they can get actually each year per physician there about $44,000 to $56,000 or something like that. Payments that are done through the EHR incentive program right now.
That doesn't count the cost of installing the
No. This is the money that is given because they are implementing or they have adopted already, but they are going to participate in the EHR incentive program and making some adjustment to their systems. CMS is not going to pay you all the money that is needed to implement EHR. Okay, that is not fair also actually. 11.6 on average hospitals actually can bill for like about $2 million or something like that. So in the stage under the stage 2 requirements where actually hospitals have to satisfy a certain more rigorous level of criteria, but it started only recently, so the numbers are small. Well, I've been talking about the stage 1 or meaningful use itself. What is meaningful use? But this is the laundry list of expectation. The actual laundry list of requirements are in the next. So the idea is meaningful use is if you use the technology properly, with the intended purpose, consistently every time, you are expected to improve the quality, safety, and efficiency of the IT system. The healthcare delivery. So this is sort of a list of 14 criteria on which the hospitals. For physicians, it's about 50, there is one more actually, 15 criteria are there which are actually core objectives. They need to meet this if they want to get paid under this EHR incentive program. Okay, and most of these are related to actually about the data capturing. There are something called menu options. I don't know who came up with the idea of menu, but whatever it is, maybe because we choose food when we order at the restaurant, so it's probably because of that. So because you have a choice of here, any 5 of 10 you can satisfy, and you still get paid. Whereas the core is something you have to do it mandatory. So it's like a core courses that you do for your program, and then electives. So what is the current status? Of course, the most recent is not known, but this is based on actually the paper that is published from here. I'm forgetting the first name of the first author, but Wright et al. And what they have done is they have looked at that time point what was the recent latest information published by the CMS in terms of what is the level of compliance they have. All the physicians have achieved on those 15 core measures and menu measures. So it turns out majority of them actually have satisfied to a great extent. 90 to 100% compliance they are showing, even though the threshold is like, for example, in some criteria that may be saying that, okay, at least 30% of the patients should be given, say, discharge instruction. I'm just saying for the illustration purpose. That may not be the correct one actually. But then maybe that everyone is giving the discharge instruction to 70% or 80%, something like that. Okay, so now physicians, there could be actually two different types. One is the primary care, the physicians to whom we go and on the routine consultation. The other is the specialist who are called upon only on need basis. So it turns out the physicians are actually complying with CPOE active medication list and vital signs more often than the specialists, whereas the specialists are doing much better in terms of maintaining problem list, which of course helps actually for them to make the decisions. Patient demographics, smoking status, and after visit summary that they give out. Okay. However, among these 15 plus 10 options, there are certain situations where the providers can actually waive in, ask for the waiver, and that's basically the exclusion criteria. And it turns out actually out of all the physicians who are getting the payments, 90% of claimed at least one exclusion, which are, it is not that all the 15 core and all the any 5 can be actually asked for exclusion, but there are certain things which have been identified, predetermined that okay, these are the ones you can actually ask for, just because there are certain complexities involved in implementing those rule criteria. On the menu measure, it turns out the 5 top menu items that are being opted by are drug formulary check, immunization registry, patient list, and lab results integrated in the EHR system as a structured data. And finally, the patient-specific educational resources that they can identify through their EHR system based on the information that is available in EHR system on the patient history. The 2 most common exclusions are actually syndromic surveillance and the immunization registry, which are basically related to public health. And it requires integration with the external data, external systems. But what is the status of the hospital? I don't know in terms of these kind of numbers, because no one has actually yet published. If anyone is interested, they can do it. It's quick and easy, but it's just that no one has published it yet. I don't know why, but people are actually using those numbers now to crank up other types of papers. And one of that is what I am presenting today. However, based on certain survey, it has been reported that out of 3 out of every 4 hospitals in the country actually has implemented basic EHR systems, which actually can satisfy the stage 1 meaningful use requirement. Okay. So the question is, what is the potential link between hospital-acquired infections, where actually most of the work is done? It requires actually a physical intervention, there is no IT intervention there. On a notional basis, that is the case. So even if you go and look at what are the recommendations they will say for reducing the infection, etc., everything will say wash hands, this, that, and so many other things are okay. But there are certain things which can actually be implemented through the IT systems. Now, one of that is alerts, and if the alerts are given on time for certain type of state for the patients, when what happened, it might actually help. And there are some case studies which I'll just talk about. But this is actually based on the survey of the physicians, which shows with the recent data that they do find that the alert systems are actually helping them. The other aspect is also that it is actually not helping them because too many alerts. So that slide data I'm not showing, but if you want, you can go and read the paper, and it's a here what is alerted you to clinical lab values, whether it's available or not. Alerted you to a potential medication error, especially when you're using the decision support systems. Help you identify needed, what type of lab tests are needed. Okay, helped you order fewer tests due to better availability of results, because if you have the most recent version history of the patient, then you don't need actually to do certain tests. So there is an increasing number of physicians who are actually giving positive impact. But then there are negative impacts also. Inadvertently led you to select wrong choices for the medications or the lab orders, okay, and led to a potential medication error in overall. So about 15% are saying that is also happening. So here is in terms of the infection, it is more about the economics and like how I want to actually link it with the IT in the future as part of this study itself. So as of now, the average cost of any CAUTI infection is about $600 per incidence. So if I am going to the hospital and if I get it, then it basically add up about $700 to my bill. Okay, which is the direct cost, not it does not include the other indirect costs that are either borne by the provider and or even by our patient like me. Okay, now this is an example of one of the earliest demonstration project that was done to show the previous slide that I talked about, the alerts. So this is something like that. So here they embedded certain rules in their clinical decisions in the CPOE system, and so that actually it turns out helped them to reduce the CAUTI based ray from 36 per 1,000 catheter days, catheter inserted days to 11. So it's almost like 1/3. It became 1/3. Yeah. And on the other example is where actually in the nursing charting done by the nurses, and that clinical module, and then the order entry, everything when it got embedded with the evidence-based guidelines. This particular demonstration actually helped to show that the hospital-acquired pressure ulcers, okay, that came down, and this is one of the example of those other 8 hospital-acquired conditions on which the penalty is about 35% of the payment score. So that also came down by almost by half it became. So there are instances like based on the demonstration projects that it does happen. It does help if you implement the right kind of system and improve, use it on a timely basis. It does help in improving. But what is the situation actually in terms of the national level data? Like if you want to look at all the hospitals, how they are performing on average. So for that actually we don't have much, except that there is only recently few studies which have come up in talking in terms of the linking the health IT use and the patient safety performance. So there are about 3 papers that got published recently last year, which provide a positive spin to the story. Okay, and fortunately one of that is mine. So that came in the AJMC. Of course, there are a lot other papers, but I'm not going to talk, and I'm not going to talk even about this paper much. But the basic idea is if you are looking at the EHR meaningful use and the patient safety events, adverse events that happen during the inpatient care, it turns out that relatively speaking, the hospitals who are actually at an advanced stage of the EHR, who have a better EHR systems that satisfy the stage 1 meaningful use criteria compared to those who do not have, on relative term, it's about 7 to 26% lesser adverse events are happening. Okay, but when it comes to hospital-acquired infections, which is one class of the patient safety events, there is not much research done, at least on the national level scale. So that gave me the chance to work on this project. Okay, that's how it came. So the objective is basically to examine the association between EHR meaningful use at hospitals and then look at their link with the hospital-acquired infection performance. Where do you get the data? Okay, so I collected the data. Usually I collect, and it is by and large, it's a norm for me that I use publicly available data sources. and so it will have its own limitations. But for the hospital-acquired infections, you can actually easily get from the Hospital Compare, which is a data repository maintained by the CMS. Then meaningful use scores that is easily available on a click from the CMS website itself. So those, how many of you are PhD students here? Anyone? Okay, one is there. So all of you are master students? That's good. Okay. So maybe you can sell my paper to the practitioners then. So in the future. So here is the thing. Even if you are not doing research, if you want to talk about a positive case for the EHR system, then you need to know where you can actually get the data, and especially and these data are actually relatively easy. And the other data that is necessary for doing this type of research is to account for hospital structure, inpatient prospective payment system that gives you certain type of data. So what is the study unit of analysis is actually here trying to look at the hospital level. This study basically like what is happening on average in the hospital in the observation period of 1 year plus 2 years actually. The data that is released is based on the 1 year, 12-year observation period. So the CMS actually releases every quarter. So I actually matched the data from different sources, and finally what I have is about 6,000 plus hospital years that so on average you can say about 3,000 hospitals if I assume that each hospital has 2 observations. Okay, but it is not the case. Actually there are hospitals who have only 1 observation, so it is the actual number could be the number of hospitals in the number of unique hospitals in the sample would be about 3,500 or something. So what are the parameters on which the study is trying to look at? And that is the dependent variable. So as I mentioned in the beginning, in the CAUTI, which is the catheter associated central line, and then apart from that there are 2 more infections that I have selected. The other is actually you don't have data on all the measures, only 4 or 5 are actually given out. So surgical site infection, from abdomen hysterectomy, and surgical site infection from colon surgery. So these are the parameters on which the numbers are published on a quarterly basis. Even though it is quarterly basis, the data is published, but the data is observed for the patient safety events is actually for 12 or maybe it is more actually, I have to check up. Okay. So each hospital actually reports to the CMS. But it is a longer time duration. EHR meaningful use measurement, so this is where actually I adapted the idea from the concept that was developed here in this school. Okay, the Wright et al. Papers in that. I mean, I modified it. I didn't use actually as it is because for my analysis I needed in some certain way. So what I did is the 14 core measures, each hospitals are providing the score from 0 to 100% satisfaction, whether they meet the criteria or not. And there are certain criteria which are yes or no. So when it is yes or no, then I actually give a score of 0 or 100. Because 100 is the maximum you can get in the continuous scale. So if you are doing, that means you are doing every time. Exclusions, if there is an exclusion allowed, then you don't get a point for that. Okay, and then you add up all the straight linear sum. I don't do any combination or anything. And then likewise in the menu option where only 5 are allowed. So there may be hospitals who are actually going for more than 5 menu options. Then in the same way, there are some converted to one sheet. Okay, this is a there are some typo errors. So 0 to 100, that is get converted into actually 0 to 10. So in that way it is done, because I wanted to reduce the total score that gets to a smaller scale actually. So 0 to 100 can be reduced to 0 to 10 because it is basically 10% point. And my inferences are also actually based on that for 10% point increase. And then the exclusions are allowed or not. So what type of statistical method that I used here is actually, it's important to understand why certain methods are used, and that is because we are actually observing the number of these infection events that has happened. Okay, I'm not actually analyzing the rate by itself directly by giving to the regression command. Instead of that, what I'm looking at is how many events has occurred, out of how many, and out of how many goes on the right side of my equation. Okay, so which in a way is same as using rate on your left hand side of an equation if you want to fit a I think they have, I saw only recently, where is the pen? Is there? There is. So
It's always an issue.
yeah, I don't know, does it right? Yes. So I don't want to bore you with the numbers, equations, but I saw in my class which I'm co-teaching here with Jonathan, so he was using this. So I thought, okay, this is a nice one. So this is what I'm talking about is this Y. Y is number instead of rate. I can use always rate also. You just need to do a different way of analysis. You have to analyze in somewhat different way.
You're taking into account the opportunity size, right?
Yes, yeah. So when you do the binomial regression models, you actually have to provide the numbers on which these incidents occurred. So that is the how many, which is basically the opportunity size. Yeah. And then you look at what type of hospitals and different parameters. Okay. Apart from that, there could be many other sources of variation, like from state to state regulatory environment changes. There are other environmental factors which actually change. Environment in the sense not climate itself, but that is relevant for the operation of hospitals. And then over time, the hospitals may be making some improvements, and as a result, you don't want to attribute that to EHR improvement. Okay, so we have to actually tease out all these potential other sources of effect that may be actually there in the variance of your events of the infection events. Okay, so the summary of the data is basically this. On average, there are 8. Okay, I won't go into the decimal, but on average, and any hospital, about 8 CAUTI infections are happening out of 3,800 events. Okay, so it's sort of 2 per 1,000, and usually these rates are reported like that: number of events per 1,000 days of catheter insertion. Okay, catheter days it is called, and then central line days. Basically, how many days actually the patient has these catheter inserted or central lines, the other types of instruments. Okay, and then this is actually the number of surgical cases actually. So 0.9. I mean, okay, if you want to actually count, so it's basically 9 out of 1,000. Okay, then likewise, this is 2.4 out of 93. So just round it off to 100. So it's basically 2.4%. It's 0.9%, and this is, I mean, if you want to think in terms of percentage actually, and this will be actually basically almost same, so you can say it is about 0.4%, and this is 0.5%. Okay. So what is happening in the level of EHR meaningful use score the hospitals are reporting? On average, on the stage 1 core measure, hospitals have achieved 56% compliance in a sense. Then in the second year actually it has improved to a higher level, because more hospitals have actually reported, and they have when they went for the second attestation they have increased. Then for the menu option it is 23, which jumped to 36, overall 79 to 106. Okay. and what type of hospitals are there in the sample. So 33% of the hospitals are actually teaching hospital, like here what we have in the medical center. Okay, and for profit, I don't know if there is any for profit here or some other places, but there would be definitely. Cardiac, these are actually special structural characteristics that one has to look at, because it indicates the level of medical technology and the resources that are available at the hospital. Okay, that makes a large difference in terms of the quality of the care. So, how much time do I have? I probably will be, oh, that's good. Above higher, there's another. So, yeah. Now, there are many other parameters that I included actually in the analysis. For example, whether the hospital is in the rural area or in the urban area, or actually more specifically large urban or the outer urban, because it makes a difference in terms of the patient population that you are treating, as well as the resources that you have, because not everyone wants to go and live in rural area, bed size, which is sort of another proxy for the hospital resources. Small hospital obviously has a smaller patient population, as well as less staffing, less money. Okay, so they, in fact, even in the EHR implementation studies, a lot of these reports that come often tell small hospitals don't have money, and that's one of the reason why the EHR incentive program is running, actually, to make sure that the smaller organizations and the physician offices are actually implementing them, so that the IT implementation goes to high level. Because when George Bush said, okay, in 2014 we will have a fully integrated EHR healthcare system, well, that is far away now, right? He announced it in 2004, but we are not. By 2009 only we got the High-Tech Act, and this EHR incentive program started in 2011. So ultimately, instead of free market approach, government approach has to be actually taken into consideration to increase the IT adoption. So yeah, there are issues which actually influences hospital decisions as well. So any study actually needs to account for various types of factors that are define who these hospitals are. Okay. So what did I find? Well, the overall summary is we did not find good results here. Okay, there is only very partial evidence, but there could be many reasons why it could be, why it could not be, and that is exactly the purpose of bringing this out and opening the bottle here now, to try to understand if there is a problem with the mixing of the grapes. Okay. So what I found here is, on average, with the 10-point increase in the meaningful use score for the core measures itself, which is actually about 14 items, right? There is the effect is associated with about 0.03 cases per on the right, so it would be basically, yeah. Yeah, it would be with the 10-point increase, it will be actually 0.03. So which would be like, okay, 3 per 100 you could say, or it will be 3 per 1,000. So then the menu measure, it will be actually on the negative. Now, by and large, we think that when an effect is plus number, it's a good thing, but here it is actually the negative which is supposed to be good number. Okay, because if you are doing better in information sharing, if you have a better alert system, if you are actually documenting the patient history properly, then there is a better likelihood that the physician should be taking the decisions of removing the catheter or the central or making sure that they are actually doing the necessary regular maintenance that is done on a day-to-day basis more effectively. So the incidence should come down actually. So as a result of that, actually the coefficient should be negative, and which is actually happening in the menu, which is sort of a strange, but one has to actually go through maybe that certain types of functionalities are actually making more difference rather than the aggregate numbers. Okay. Whereas for the other coefficient, the other infection measures, I did not find. I mean, there is some numbers which, in the sense like there is some effect, but it is actually not statistically significant. And so, since it is not statistically significant, so there is no effect. In other words, the hospitals who are scoring less in the meaningful use versus those who are scoring very high, they are same when it comes to these infection events in the hospital. So likewise, even for the surgical, actually it does not make difference. For the colon surgery based surgical infection, it's not making any difference. So that is basically the summarization of that. I will leave you with the questions if you have, or if you can poke some hole in the study. Actual study is only the last part of the presentation. The beginning was history.
So I'm not surprised. And when I saw your talk title, I wondered why you would think of it that. Because I
Yes.
work with EHRs, I work in quality improvement, and I've got like 5 years of experience. Kentucky was at a fairly high level, but I was on the monthly meetings where we reviewed all the AHRQ patient safety indicators and core measures and all that. The EHR, they had one, played very little role in improving those numbers. Very, very little. So I suspect that any effect of EHR use is just washed out by noise. You can, yes, in some places you can have a targeted intervention.
Yeah.
So we're working on substance resuscitation here. And there's some health IT components. It's truly unclear that they'll make that much of a difference. There's certain things they can make some difference. But there's just so many other factors. And a lot of it's workflow and culture. A lot of it's complexity of healthcare. And in the ED, lots of things are going on. You're not just worrying about patients who may have septic shock, right? There's a lot of other things going on. And yet we focus on these indicators and think that somehow everyone else can just focus on those and they can't. It's unclear to me that at this high level, we'll ever see much of an effect that you can directly tie to EHR, particularly meaningful use, because meaningful use isn't meaningful. I mean, the measures, you listed them, and most of them are a joke. 30% of prescriptions are electronically transmitted, or 30%. Okay.
Yep.
So, it's a step in the right direction, and you certainly went through a great analysis. I like how you pulled the data together. I'm not surprised by your results at all.
Me neither. I am also not surprised, and I was actually not expecting to be frank. Now there are other things that one could do, like as you mentioned, in terms of looking at the data in different ways. Now there are certain data on certain types of factors which are like cultural, etc., is not available. Actually, if one has access to a certain type of a survey which is done at the Leapfrog, so one could do actually. I'm just tied up with the faculty at the UH, and we are trying to do something. So maybe we will do something along that line in that. But yes, it is true. And the other caution is also this, that so the benefit of EHR systems by and large usually is demonstrated through single site projects. Okay. But when you are making a policy decision, you are looking at the bigger picture of what is happening in the entire country. Okay, because then you decide actually how much money to put it in this basket or that basket, or whether you want to actually influence these many states to take up certain type of initiatives. Now, any number that is measured at the economy, at the country level, the fluctuation in that is always very small. Okay, just like if you, I don't know how many of you are interested. I mean, of course, I don't have that much interest anymore in the finance numbers. But when you look at the the GDP or GDP or any other these national numbers, they change very small. Okay, but with that small change, it moves the mountain. Okay, we don't expect that mountain to be reflected in those number. I mean, number in its absolute size actually. So same thing happens even here in study like this. You will see very small effect size. The question is whether it is statistically significant or not. And because we are using the larger data, I mean, of course, this study does not have a really very large data. It is only about 4,000 hospitals, but that is the whole sort of a representation of a whole population. But if we have like actual information about the individual patient level data, then you can actually do a much more rigorous analysis, and you can get that time more meaningful interpretation of the numbers. Notwithstanding, with the way the meaningful use criteria are being implemented, or I have one. This is something not. I mean, I have not debated with the others, but a lot of times in these empirical studies, here of course there is some number that is used on a larger scale, from 0 to some 100 plus or something, where you can actually tell, okay, what is the level of IT use that is happening. But most of the studies, they simply use whether 0 or 1. That means you have an IT system or not. Which is to say, it does not mean that when it is 1, it means it is just there and people may not be using, or yes, but that 1 actually represents the average performance of use. It does not indicate whether they are using 100%, no. In a study like this, that the 1 says it is the average use level. So I may be using, let's say, smartphone 0 number of times a week, you may be using 10 times a week, or you may be using 3 times. The average of what is that is the smartphone use. Okay, so mine is 0 because I have a flip phone.
So did you find any relationship between size or funding of a hospital and the measures at all?
No, I have not done actually. Funding of the hospital means the money that is given to them, so that data is not available actually.
Because my experience is that hospitals that have a lot more money have more people to gain the numbers.
Yeah.
Because first
Yeah.
you gain the numbers. And
Yes.
So medication reconciliation, you know how you improve your numbers on that? You put a
There are
checkbox,
always ways to.
You put a checkbox and the physician checks.
Yeah.
Puts that box and says, I've done medication reconciliation. So you can have 100% compliance. And they might look at the list, but they're not doing it because it takes a pharmacist 1 hour to 2 hours per patient to do proper medication reconciliation.
That's right.
And they
Yeah.
don't have time to do that. So it's a joke. The whole medication reconciliation measure is meetings.
I see my question would be out of that selection list, did they select things that they were already predisposed to appear?
Yes, it is actually, it is possible. It is possible. So here is the thing. Yes, that is true.
There were some that you couldn't select, you had to do.
But then you could also have deception.
Because they wanted some flexibility and it was a give and take. Sort of.
Yeah, we have,
Yeah.
let's hand out some, how do we do?
And I mean, the other thing is, the question would be how long these hospitals will game the system, game the systems sustainably. Okay, because the money is given out, like say for the 4 or 5 years, and then it will. But now from this year, actually, the penalty has to kick in. I don't know whether, I think it has started already.
The measurement.
Yeah, if the performance, because going with that argument, of course, what it would require is those set of individuals to do this continuously, but does not really happen. Okay, that was my alarm for that we have, but it is. Okay, so yeah. Any other question? What we do?
Someone else ask a question.
Yeah.
Otherwise, my my question is, what do we do? How, should we even try to show that EHR technology improves things, or should we do more targeted studies? Which, yeah, we're wrong. I just don't
No, yeah, the targeted studies are being done. It is just that the inference from making inference from individual targeted studies could be actually dangerous. Okay, because that same number does not get replicated everywhere. That is the idea, and the reason is what you mentioned, cultural difference, this, that, everything is there. So suppose, if I am running a hospital and I implement the system, and like one of those case study we showed, the CAUTI rates dropped from 36 per 1,000 catheter days to 11. Well, that may not happen in, say, in Memorial or some other hospital if you do the same project. Actually, the other problem is with this demonstration project is performance if there is a performance improvement, generally it becomes very large because everyone is doing to show that the system works actually. But they are not doing it on an average day-to-day routine lifestyle. Because that time what you get is the real reflection of the benefits. And that you get if you average out. And in a study like this, of course, it's always difficult to actually extract away the effect of all the other factors that is influencing these numbers. So one can do to the maximum to a certain level, and so that is another type of limitation that exists actually in this type of studies. Yeah, but it's useful. I mean, otherwise I wouldn't be doing. So, any other thing?
So your numbers that you quote, the 3.6 or 36 to 11. My first question when you showed it was, how do you know that drop was associated with use of the EHR? Were they
no. So okay, the 36 to 11 was actually not my number. It is a study that is actually funded by AHRQ. It was funded by AHRQ. It is a part of a demonstration project that was done I think it is in Pennsylvania or somewhere.
But regardless of who did it, that's going to be the first question of most people is how do you know that the drop was associated, any of the drops were really associated with the use of the EHR? Because there's really,
yes, so they did a exclusive project. It's sort of like a random control experiment. It's an experiment actually, experimental study that was done. Certain number of, in some unit actually the nurses and the physicians were using that system protocols, and then after that they saw what was the net result over about 12 or 18 months time period after the implementation, and before the implementation what was the status, and they compared and they reported in a journal published article as well as the report to the AHRQ. So that is there you could potentially say, because the same people were actually before and you are measuring the performance of those people, and then same people you are after that, the only one major change is the change in the system that they are using.
Yeah, I just think usually you're going to have a hard time convincing people unless you do a lot of clear talking and a clear explanation on what the controls were. So that'll be the first kind of issue. But the next one, it goes along with what Todd was saying earlier. Every time I hear meaningful use, people talk about EHR. We spend a lot of money on it, but it doesn't seem like people ever really started out with a good idea about what it was really supposed to accomplish. So we spend a lot of money, but nobody can actually say what the benefit was, and that really just surprises me. And we continue to talk about meaningful use in EHR. Most people think like what you just said, but what is the real value?
I think that it's important
Yeah,
to do your
so-
studies to show,
yeah.
to see if you can at least detect it.
So EHR system, it's an enterprise level system. Okay, the benefits can be derived through many functionalities. It's not a single functionality, like I don't know how effective you can browse while in the class on the smartphone. So that is the device. Usually we are tuned to using certain type of technology pieces where it's a unifunctional, or at least there are small set of features. But EHR systems are something which encompasses the entire organization. There are a lot of people who are actually at different role level they are playing. Now the idea of actually having a good EHR system is you are feeding in the right type of data in the right time. Then you are extracting that data, making, there are different ways actually the data needs to be used. One is on a day-to-day clinical decision, but the other is the administrators who are actually compiling these numbers, because when they sit and review the performance of the organization for making next level of hiring or making whether to build another floor or anything, they have to look at what is happening, right? So there they are aggregating the numbers, and these aggregated numbers, if they are coming out of the EHR directly, hopefully they will be more reliable actually, and you can see a better pattern, unless everyone is gaming and changing that button click, which is actually for the payment system.
The way that these numbers are reported is
Yes.
that someone sits down and reviews every case by
Yeah, well, that is, I don't know why it is being done yet. That is actually, that shouldn't really be the way. It should be actually, it should come out of the system without any intervention actually, without any physical intervention. It should come out directly. But people have not developed that.
They're not thinking AHRQ patient safety indicators. They're thinking take care of the patient, and they document what they need to document. They do what they need to do. And if they happen to enter something 6 hours after they measured it, the time is stamped at 6 hours after they measured it. And so,
Yes,
you know, there's things like that. There's also things in the way these metrics are designed that are poor, like if something was present on admission and it wasn't documented by the right person, it counts against you. So there's all sorts of problems with these metrics. The sepsis one, the experts disagree that some of the metric parts of the metric are even appropriate to have. They don't matter. They don't matter. There's not evidence that they matter, and yet we get dinged on them. So, you know, there's so many problems. And,
Sure.
and the way we report our metrics, even though we use the EHR data for dashboards and things, is by having a person sit down and review every case by hand. There's no other way to do it accurately. It's not in the electronic, it's not in a structured form in a reliable way.
Yeah. Well, that is where the school like SBMI comes into picture, right? To develop structuredness in the, I mean, that is why we are supposed to be graduating these master students so that they can go and develop, right? Or at least influence the industry in some way. How many of you are doing programming? Or everyone just want to do some other kind of a job after this?
I don't think the problem is really in the programming or tools that develop. It's because it ends up being people in the.
No, it's about actually defining the requirements correctly. All the systems are actually screwed up because people are not defining the specification correctly.
I mean, it's, these metrics are things.
Programmers are pretty much good actually in developing systems.
These systems weren't exactly designed to help doctors take care of patients and nurses.
Yeah.
They're designed for a whole bunch of reasons that have nothing to do with that, such as our Byzantine billing system, and the codes and all this, and the billing rules that go along with what you can put down as a code, and what you have to document.
Yes, I agree there. Yeah.
And then we're trying to use it, these are secondary use.
Yeah.
And it seems like a no-brainer until you actually do it. You know, and I forget who, Informatician, it was a 1997 paper from Acme. Informatics is not a spectator sport. You have to go in and get your hands dirty on the actual data. Because the actual data is much messier. It seems like this should be a no-brainer. I agree. We should just get it out of the system, but it doesn't work that way. And after having experienced it, I don't have an easy solution as an informatician as to how to solve it. Because I think if you start making them document more and more and more and more accurately, it's going to actually affect patient care. Because now they spend so much time trying to make sure they get everything right in the system, that they don't have time to actually take care of patients.
Yeah, I mean, hopefully the system design and the technology is moving in such a way that actually those things could be addressed in future, I suppose, because nowadays most of the thing probably you don't have to document.
So,
you know, once we have a really reliable voice recognition system that can actually transfer the voice to text for all types of people. Now that is the bigger problem. You can always build which will actually work just for Ajit, but you cannot build it for which will work for the entire class at the same time. because everyone has a different voice pattern.
So automation
And
can
so
help, but
at that is the time when you can actually automatically capture, and then you will have a right type of a timestamp also.
Right,
But
so when they
till
do
that
that
time you
now,
can.
and if you take a machine from one patient to another that does vital signs automatically, they often forget to change the patient information. in the
Patient,
machine,
yeah.
And now the new patient flows into the old patient's.
Yeah,
record.
yeah.
It's very good automatic data that's completely wrong.
Well,
So that's an automation.
so it's not really an automation error, it's a user error. Yeah, but it is again a user error
No,
because
it's a system.
you, well, system is made of users and the machines. So
Yes.
everyone say that it's system error. System error does not mean some third entity actually. It is we.
So this is the discussion we need to be having.
It's good.
Yeah. Yeah.
So shall I close
If you
this?
haven't worked with real data, I really recommend you work with real data. Get involved in a project in the hospital, in a clinic, and work with real data. It is not what you see from the administrative data. It's highly unreliable.
How do you close this?
Oh.
Pause your webcam.
I don't know that you need to worry about it.
Okay.
So just close the